So as a speech pathologist, I work primarily in 0 to 5 age range. We look at, we have education and training just to get kind of everyone on the same page as to what we do, to assess and manage children in the areas of social communication, understanding and use of language, speech sound production, voice, fluency, and then we also do have a role when it comes to feeding and swallowing. We often work on a team when it comes to anything with feeding and swallowing with the children. And I'll get into kind of how we approach that next. But I thought what I could just help do today is, I know everyone knows what a tongue tie is or ankyloglossia is, just do a quick review. I'll go over how an SLP would approach a feeding and swallowing assessment, and then just a brief review of some of the literature or expert opinion around tongue tie and feeding, and then finish it off with some tongue tie and speech sound production. So we all know the lingual frenulum is that small band of mucous membrane, which connects the middle part of the tongue to the bottom of the mouth. And it's really important for stabilizing actions such as sucking and swallowing, speaking, and that when you get a tongue tie, that occurs when the child's born with a short or tight frenulum that fixates the tongue to the floor of the mouth, and it can be partial or full. And then a term that we hear often in the speech world is about posterior tongue tie. That's kind of become a bit of a fad, I would say, especially as it relates to posterior sounds like K and G, that people will say, well, do you think it's a posterior tongue tie that's inhibiting children from being able to produce those sounds? And I was like, there's not a ton of research around that area. It seems a bit subjective because it's not great. It's not something that's very easily assessed. But it is very common that you will hear that in the speech, in speech world, especially as it relates to speech sound production. And that's just a little picture that just shows a babe with the that heart-shaped notch. And so when we do an assessment of a child, whether it's for feeding or speech sound production, we always want to do a very thorough oral mechanism exam and to look at all the structures and how everything is working, and how the muscles are moving in the mouth and how children can coordinate some of the movements. And so we would always want to look at tongue movements and how a child would the appearance of their tongue, and then also how it functions. And I know from that other talk I watched, and based on what a lot of the research says, is we put a big, not only on appearance, but we put a big emphasis on function as well. So just because you can see the tongue tie, but that's not necessarily giving us the whole picture. And now I know you guys you probably have more information about like objective measures of tongue tie, but I think that's something, especially in our world, that's really lacking, is we don't really have any training on kind of like objective measures of a tongue tie. So we're kind of left with just a very subjective view on it. The tongue seems to be functioning well, and they're able to produce this sound. So I think that's a speech pathologist, I feel comfortable saying, at least from my perspective and the colleagues that I work with, is that we don't have a lot of training when it comes to like objectively measuring that. So that's why often we refer on, but you know, putting this talk together and kind of really reviewing it and talking with some colleagues, we came up with some really, we want to use what the research says to make sure that we're making best choices and informing families well. So in terms of how a speech pathologist approaches feeding. So like I said, we can be part of a team who manages a pediatric feeding and swallowing difficulties. And that team often involves the caregiver. We work very closely with dietitians. From everything I read, we have this resource that I tap into for literature specific to speech and language pathology and as it relates to feeding. And everything was very clear, especially if it's a very young babe, that breastfeeding is the primary goal of the family, is that we need to find and make friends with a really good lactation consultant. And they are the key member of our team. A speech pathologist can be in the team. We often in pediatric feeding is very common that you work with an occupational therapist, nurse, physician, and in older children, teaching and teaching assistants often become members of those teams that we draw on their resources. So this is resource out of Holland Bloorview about optimizing feeding and swallowing in children with physical and developmental disabilities. And it was a practical guide for clinicians. And I thought when I looked at it and my experience of going to a lactation consultant, that it did a really good job of kind of looking at feeding from a very holistic view. And it made me think about how we do approach feeding assessments as a speech pathologist. So the triangle, we have to make sure at the bottom when we're taking a feeding history or doing the assessment, we would want to consider a child's medical history, their diagnosis, what the parent's current concerns are, their growth, their weight, the history of feeding difficulties, what meals and a feeding session look like at home, what distractions are present while the parent is doing the feeding, where feedings are occurring, the positioning of the child, the seating, if it's an older child seating, the child's reactions when they're what we'll also look at the oral structures and, you know, is there leaking? Does there seem to be the child overall? What's their overall tone look like? So when we're called to do a feeding assessment, it's often for a certain skill. So it might be that the child can't chew or that they're not latching, they're not taking the bottle, and that people want us to work on the skill development, right here. But in order to be able to work on that skill, we need to look at it very holistically and think of all of this foundational stuff first. A tongue tie might be part of that medical issue, but it's just one small part of what we want to look at, what an SLP would look at in assessment. And we would want to make sure that we are addressing all of these things while during the assessment and not just thinking about one thing. So it's just, I thought of it too, like I can know my experience with going to a lactation consultant and my own son, and just how they asked all about the medical history, but they also looked into, you know, how I was holding him, what I was doing to help him get latch. And it was just more than just what was going on with him. And that's the same thing when we approach an assessment is people always give us referrals and want us to work on this skill of getting the child, but there's a lot more going on that we have to make sure we take care of first. So that is basically, and that's how we would approach intervention as well. Whoops. And I just wanted to quickly go over, so when a speech pathologist addresses, we're often thought most of when working on feeding and swallowing, really when it comes to the swallowing aspect of things. So that's, I would say majority of our referrals come in is when a child is having some difficulty managing food, forming a bolus, transporting the food back to the throat and swallowing their food safely. That is more our traditional role of what we play in feeding and swallowing as a speech pathologist. And swallowing is a very complex process, and we would look at all phases of the swallow where a child's chewing or preparing the food to how it's moved back in the oral cavity, and a tongue tie could potentially come into play there if the child has a very restricted tongue movement and doesn't have that proper peristaltic movement backwards. And then is it safe when they're swallowing? So I would say traditionally a lot of our referrals come in are children with very involved, if they're going to be really young, and what we call P1 children. So children whose nutritional needs are not being met would probably be the babies that would get referred to our center. And it would most likely be a child that has very involved medical history. And we're just going to be one small part in learning that and giving some input on how safe is their swallow so we can start progressing towards oral feeds. This tends to be what we work on. And so when I was going through all the stuff when it relates to feeding, what I thought this really stuck out to me, and when I was reading all the research about it and reviewing all the research and trying to put it together in this little presentation, I thought it was always a good idea to review this idea of evidence-based practice because we always want to be using the best. And I know you said that that's the whole point of this network, is that you want to make sure that you're using the best available evidence possible to guide your decisions. And that's what, you know, we really work for here. This is from the American Speech, Language, and Hearing Association, this diagram. And it's really important because sometimes there's really a lack of clear guidance in a lot of the things that we do, and that research is just emerging, or it's not always very definitive, or it's not that like highest quality of research. So the idea of going back to what evidence-based practice is, and it's that, it's a mix of, it's all three of these pillars play a really important part, is that expert opinion and your own opinion, your clinical expertise and all the things that the nuances that you bring to the job, that the best available evidence that is gathered from the scientific literature and your observations from collecting data from the patient as well. And then just the client and caregiver's perspective. And all three of these play an important role in guiding our practice, especially when there isn't necessarily the best available evidence. And I think a similar diagram was shown in your last talk about this, is that just when we're looking at evidence and the evidence hierarchy of what kind of is that highest gold standard, and then down at the bottom is background information and expert opinion. And I can say, when I looked, especially when it related to feeding and tongue tie and feeding in older children, a lot of the information out there is really based on expert opinion and their experiences, and there isn't a lot of other research to base it on. So you have to kind of go back to that triangle and think about I'll use all three pillars to make sure that we're guiding using the best available evidence to make recommendations to a family. Because we're still going to be asked this. I get asked about tongue tie and speech sounds a lot. And, up until recently, there wasn't a ton of definitive information out there, not even definitive, but really strong evidence out there. And so, I want to make sure that when I am saying something, that it's not just how I personally feel about something, is that I'm using everything that's available to me to make that decision. So I know that you guys have already done thorough things, and you guys probably know way more about this as tongue tie and breastfeeding than I ever could. But this is from that resource I talked about. I read the article, and then this resource that I thought was really interesting, or the way that they summed it up was really interesting to me. And I thought it was a good reminder of as an SLP about how multifactorial feeding and swallowing difficulties can be. So the whole idea here was that we know that tongue tie can cause breastfeeding difficulties, but it's not as cut and dry. So in this article by Schlatter et al. In 2019, 55% of the babies with tongue tie did have breastfeeding problems, whereas 42% without a tongue tie had some breastfeeding problems as well. So it's significantly less than tongue tie, but it still shows that that wasn't necessarily it's not as cut and dry as tongue tie caused the breastfeeding difficulty. And this line right here is that, I'll go back, sorry, I'm going a little off topic, but I should finish the summary first, is that in infants with a tongue tie, overall tongue function and the item measuring tongue peristalsis was the best way to predict which mother and baby dyad would have the more frequent breastfeeding difficulties, and that other things played in a role. So looking at those dyads, tongue tie, low birth weight, birth before 37 weeks was prematurity, and lack of breastfeeding experience increased these odds of breastfeeding problems. And I know you talked about that in your last talk, that there need to look at it more holistically, and that tongue tie might be one part of it, but that all these other things come into play as well. And it really brought, for me, back to that triangle of how we look at feeding and swallowing, is that we really need to be considering all of those factors before we make a decision that this is going to be the recommendation. But the majority of moms do report some improvement in breastfeeding post-surgery to fix the tongue tie. But this line that she writes right here is that lack of breastfeeding experience seems to be the most important determinant of breastfeeding problems, which might be resolved with meticulous lactation consultation, even in an infant that has a tongue tie. And I just, as a little aside with my own experience, so my first son, I didn't even know it was a problem when I was breastfeeding my first son, that I was having so much pain until he had to go to the ER at a few days old because he was having lots of apneic episodes. And the ER doctor is the one that said to me, that looks really uncomfortable. And I was like, I don't know. And yes, but I think he's just learning. Anyways, I got connected with the lactation consultant. We worked some things out. My second son has had very severe torticollis. He had a very severe neck injury at birth. He had all these other things that you would think, you know, that really, I really had to change things with positioning. But I never had any issues. I think it was just, it goes back to that breastfeeding experience and looking at, you know, how can we support mom and seeing the issue a little more holistically. And that keeping tongue tie in mind, but really making sure we're addressing all those other things. And I just wanted to pull out of this one from Francis et al. In 2015, is that the small body of evidence suggested that revision of a tongue tie might be associated with mother-reported improvements in breastfeeding. But again, they were all small, short-term studies with inconsistent methodology, and the strength of the evidence was low and insufficient back, and that was from 2015. But it really brought back to me that evidence-based practice and using all of those 3 pillars to really guide my decision-making and making sure that, you know, we're looking at things that way. So when it relates to, feeding for tongue tie and reasons other than breastfeeding, all that I wanted to take from this was that the data is currently pretty insufficient as it relates to activities. So I did read a lot about for older children, there's a lot of expert opinion out there, especially in speech. There's a speech pathologist who is very well respected in the feeding world, and she feels very strongly about tongue tie. She's based out of the States, but she writes a lot of resources in the ASHA Leader, which is a publication that's more opinion about tongue tie, and she's wrote quite a few things, and she also puts it out there. I looked just out of curiosity on her Instagram, so parents would have access to this information just looking on these Instagram sites about how tongue tie is going to cause all these issues in feeding later on. So, you know, these are questions that I have been asked personally as a speech pathologist as relates to speech sound, but all these other things that when they've read things on the internet. But she says that there's a lot of information that she feels it can relate to poor oral hygiene, later picky eating, and difficulty with social activities. And she mentioned things like licking an ice cream cone or even kissing later on. But the research out there is really insufficient, and there is nothing to suggest that, other than as it relates to breastfeeding and nipple pain, that there wasn't a lot of information that revision of that tongue tie is going to have anything, any positive effect on those kind of outcomes. So when it comes to feeding in older children, like I mentioned, the speech pathologist that feels very strongly that picky eating, so she puts out that you really need to look at a tongue function and if there is a tongue tie when you get referred some older children when it comes to picky eating. And she feels that these are some of the things that you might see in an older child that tongue tie could be playing a role in. It goes back to that triangle. There isn't a lot of research. She says she can't wait for the research. So this is based on her clinical experience. Is that when you take a history as a speech pathologist, that we might want to be looking at how tongue tie would impact, you know, how they did with breast or bottle as a baby. You know, do they have slow feeding? If they're starting some solids, you know, is there retraction of the tongue upon presentation of the spoon, that they fatigue very easily because their tongue isn't functioning properly. She sees a lot of the overuse of the lower lip, that they didn't progress to more mature chewing patterns and had picky eating, and that you see some gagging and later dental issues. Again, there isn't research to support this necessarily, but this is what's out there and is based on picky and based on expert opinion. And this is all we saw. This is all I could find as it related to picky eating in older children. So any research that I could find mostly related to breastfeeding. But these are questions that are asked later on, is should I get my child's tongue tie clipped when they're older because their speech is not developing or they're picky eaters? And there just isn't the body of research to suggest that would necessarily be beneficial. So as it relates to speech sounds, so when a child comes in for speech sound assessment with a speech pathologist, there's often many reasons why a child might be having some difficulties producing some speech sounds. So articulation disorders is really just a child might have a distortion or a substitution in the production of individual speech sounds. If they're showing a phonological difficulty, that would be a child that would come in with a pattern of speech sound errors. So they might stop for like the S sounds for sun, or soap, they might say taupe or ton, so they're stopping that airflow. We see patterns of speech sound errors like that. Then a child might have difficulties coordinating the movements of speech. They might have some structural difficulties like a cleft palate or other oral facial anomalies. Or they might have hearing difficulties, and that's sensory perceptual reason why they're having some difficulty with speech sound. But when it comes to specific about tongue tie, so the tip of the tongue is used to produce what we call alveolar sounds, and that would be S and Z, T, D, N, and L. So st, t, n, l. And you see that if you do those yourself, there's very little tongue movement required in order to be able to produce those sounds. So it is quite common that we're asked, you know, my child has a tongue tie. Is this going to, like, this is why they're having trouble with their speech sounds. And when we do a thorough assessment, we might see, okay, well, they're having difficulty learning all the rules for the speech sound. That has nothing to do with their tongue tie. Or, you know, they might come in and their tongue's too far forward for S, or they might have a lateral airflow for that. And that's when the sound it sounds really slushy. The airflow comes out the sides of their tongues. And that's an articulation difficulty. And parents will often say to us, well, they're tongue tied, not often, but it does come up that they're tongue tied. And so that's probably why they're not being able to produce their S. And that's not necessarily the case. There's lots of reasons why a child might have difficulty with speech sounds. So we want to make sure that, like, when we come in, we'll do a thorough assessment. We'll do an oral mechanism exam, look at all the appearance of the oral facial structure, but also how each one of those structures is functioning. And we'll do a formal assessment of this child's speech sound inventory. And then we'll also want to do an examination of how it sounds and how accurate all those speech sound movements are. Sorry, I'm just going to move this around. So this is just fairly recent. This was in 2020, but Holly Salt did kind of a very thorough review of speech sounds production in young children with tongue tie. So what she did, she looked at children from age 2 to 411, almost 5, and they were formed into 3 groups as treated tongue tie, untreated tongue tie, and no tongue tie. And they assessed, you know, the structure and function, tongue mobility, their speech sound production, and did some intelligibility ratings, which would be just how understandable the child is. And what they found was there's no statistically significant difference between all 3 groups for tongue mobility, speech sound production, or intelligibility. And that significantly more untreated tongue-tied children had a history of speech pathology attendance than participants in the no tongue tie group, sorry. So it just provides some preliminary evidence that there's no difference between tongue mobility and speech outcomes in young children with or without intervention for tongue tie during infancy. So it was just the whole idea, and what the bottom line of in this resource that they took out of it is that, you know, we can't necessarily draw, is not definitive, but because it is a relatively small group, when we look back in that methodology, 59 children, it is fairly small, but the key clinical message here, and as a speech pathologist, is not appropriate to recommend tongue tie for the purpose of preventing speech sound problems in the future, because the evidence just isn't there to support that conclusion. So, you know, when on my summary slide, I didn't add, but I just thought, you know, as a speech pathologist, we work in a variety of areas. Most often our role in feeding and swallowing tends to play a part with that swallowing piece and making sure a child's swallow is safe, and examining each stage of the swallow and where that breakdown is occurring and how we can make some modifications around that, and whether that be some positioning or modification of whatever form of food the child is eating so that it is safe and moving properly back in their mouth. And then work with the child and the family to progress them as they're able to more natural ways of feeding. And that's kind of where but tongue tie does play a role in it. And we our most work in a team, and we want to make sure that kind of the take-home message is that we are communicating and working with all the teams and getting all these perspectives in place, perspectives from everyone on the team, to make sure that we're being really thorough in how we approach it, and that we're not just looking at one small piece of the puzzle, that we see it as a whole picture. So that's kind of what I just had to share is about tongue tie from a speech pathologist perspective. I know you guys have talked about this a lot, so I just wanted to kind of build on it from what you already had talked about.